Hello, everybody, and welcome to ICMDA webinars. We've got Dr. Benjamin Walker, who'll be speaking to us on 100 years of mission, health and development in Ghana. So, an historical approach to faith-based healthcare can offer insights into how government, medical groups, public health authorities, international organizations, and also spiritual communities interact over the long term. And historical analysis provides a vital but often underutilized explanatory model for developing a coherent understanding of how and why faith-based providers have shaped health over many decades. Looking back allows us new insights into intractable debates as we forge shared paths forward. And by interrogating the competing actors in a health landscape, such as Ghana, across a century of large-scale political, economic, and cultural changes, we can explore how faith-based providers have informed what global health has become. So we're delighted today to have Dr. Ben Bronnert Walker. Ben says Ben Bronnert to distinguish him from the many other Dr. Ben Walkers who are apparently out there.
There are a lot of them. There are a lot of them.
Ben is a historian of global health and religion and a fellow of the Royal Historical Society in the UK. He's the strategic portfolio manager for the Diocese of Leeds in the Church of England, and he coordinates the Anglican Health and Community Network, which is the official global health network of the Anglican Communion worldwide. And his book, Religion and Global Health and Development, The Case of 20th Century Ghana, was published in April 2022 by McGill Queen's University Press. And the research was funded by the Wellcome Institute. Ben was based in the WHO Collaborating Centre for Global Health Histories at the University of York. So Ben, real pleasure to have you here today. And we look forward to hearing your insights, not only on Ghana, but on models that I'm sure will apply right across the world, given your global role. So over to you, and we look forward to interacting with you later after your talk. Thank you.
Thank you very much, Peter. Wonderful to be here to share with you all. I know you're coming from a lot of different places and contexts and directions. So I'm very grateful that you are interested in hearing a little bit more about 100 years of healthcare in Ghana. And I hope that by the end of this, you will find that there was some fruit or something useful for your context too. I'm going to take you back to the start of the journey. I began this work in around 2014, and it was the subject of probably about 8 years archival research and interviews and other kinds of research methodologies as well. It spanned many different countries. Those of you who've ever worked on historical documents in relationship to healthcare in different developing countries, different LMICs, but also in places where there's been significant disruption in the nation state, will know that they don't all sit in a neat public archive in one country. In fact, the materials that make up the histories and the histories that we can tell of many countries are actually all over the world in different pockets, in organizations, small libraries, in the boxes of individuals, and in international organizations' own archival stores, and sometimes simply in the memories of those that lived through them. So my research went all over. Much was done in Ghana, but also in the US, to try and build one story of where healthcare emerged and came from in Ghana, is that we simply cannot take out the role of religion, of mission, and particularly of Christianity. You can't tell the story of how things emerged and why Ghana's healthcare is set up in the way it is now without understanding the many different kinds of people and many different kinds of religious interest that went into forming it, to resourcing it, to building it, to passing it on, to fighting over it as well. the book that Peter mentioned that came out in 2022 is the bringing together of that story. And it is the Wellcome Trust have made it freely available online. So if you type in the title of this book, you will be able to access it and access all the different chapters in it. The thing about a history which has many different actors and many different organizations is finding a thread that tells us something. What can we gain out of this that is useful for today, if anything? What can we understand about these past that maybe has been lost? And what can we draw out of many different experiences that give us an indication of either what the future will look like, or what it might look like, or what it should look like if we want to build new visions of our healthcare? And the essential story that came out of this research for me spanned around one individual. And that individual was a man called Frank Grant. He was the first Ghanaian epidemiologist. And I actually have a picture of him. Frank Grant is at the front of that photo there in a CDC staff dinner, Centre for Disease Control staff dinner in 1967. And Frank was an extraordinary outlier in the creation of healthcare at the time. And what he tells in his life through his health work was that far from the narrative that Ghana and other nations which are under-resourced and which may not have strong healthcare infrastructure, far from the narrative that they are simply recipients of aid or even recipients of development ideas, Frank Grant himself was creating global health programs. He was driving them from Ghana and doing it in a way that no one could ignore. Frank was doing smallpox control in Ghana in the 1950s and 1960s until they eradicated the disease in about 1968. But at the beginning of this process, even though smallpox is the health historian's favorite go-to of a big success story, if you go to a medical museum and look at, I know there's one called the Thackeray Medical Museum. As you enter, on your left, there is a pedojet gun, which is the famous tool of the smallpox eradication program that led to the overall eradication of the disease worldwide. It is a triumph of human endeavor, and that's why we love going back to it. But who actually made it happen? How did they make it happen, and why? To understand that, we have to go back to people like Frank Grant. At a time in the early 1960s, when people weren't that interested in smallpox control in a way that only a few years later they would be, but Frank was interested in it. And he kept on knocking on the door of USAID and kept on pushing for it. And the reason he wanted to do it, he had ulterior motives. He knew it would be a bit of an easier win than other diseases, but really he cared about controlling and eradicating measles in under fives because it was such a scourge in Ghana at the time. He kept on knocking on the door of USAID, and there are quotes from the time where individuals say things like, "We just couldn't ignore it because he wouldn't go away." And these are USAID officials from later that I'd interviewed. Frank got smallpox control and eradication going in Ghana. And because he got it going in Ghana, it became an example to other countries. Frank, eventually having run it in Ghana with teams of Ghanaians working and interacting with all different parts of the health system, was then able to join a WHO expert committee and was part of eradicating smallpox in other countries around the world as well. One of the reasons he was so important and unique in being able to do this is he was the son of the head of the Methodist Church. Frank not only had the epidemiological knowledge, he not only had great stakeholder relationships with international organizations and with government, he also knew the churches and he knew the communities. Many of you all know that with scientists and global health organizations research, that they can go far in challenging or taking on a particular health issue, but they can't do the last mile. The last mile is very difficult. The last mile into communities, the last mile where trust is the most significant asset that you have in finishing and getting towards the completion of a health program, to actually getting the vaccine into people's arms, actually being able to distribute the right health resources, being able to share the health knowledge that's needed, takes the last mile. Frank Grant was someone that could do the last mile when no one else could. He was able to bring together lots of different interests and lots of different parties, but he also had something that no one else had: the relationships with the churches, with the Christian Health Association, with the Christian health organizations, with the Christian clinics, with the hospitals, with the dispensaries, that meant that he could navigate really complex logistical challenges. Frank isn't the only one that was doing this, and he's certainly not the only Ghanaian that has had a colossal role in shaping what global health has become. But he's a particularly striking example of how one individual was able to do that because of his relationship with the faith in health infrastructure that was growing in Ghana at the time. Today, Ghana's health system has around 42%. That was about 10 years ago. There was some research. Around 42% of the health infrastructure is faith-based. But that didn't come from nowhere. If we look at the earlier maps of the kind of 1950s and 1960s, there was a rapid growth of Christian missionary health establishments all across the country. There'd already been developments in the 1920s and 1930s into the development funding of the 1940s, but it was the 50s and 60s and then into the 70s where this became rapid. One of the things that my research shows is that a lot of the funding was coming from Germany and the Netherlands. And what I won't unpack here, but what you might be interested in looking at further, is that the resourcing and the funding that was coming from Germany and the Netherlands was made available largely by ordinary Catholics. These are ordinary Catholics who, in the aftermath of the Second World War, were rebuilding their identity in Germany, and we're looking for ways of doing that. And part of the process of doing that was these big fasting campaigns. And these fasting campaigns, called Fast and Action, were where ordinary people were giving up food in order to donate to health work and to famine relief, and generated tens and tens of millions of Deutschmarks in doing that. And one of the effects was the creation of healthcare systems around the world, including in Ghana. There were also missionaries involved in that process. I interviewed some who began in the 60s and who had grown up in places like Berlin and chose to go and be part of like a kind of a sense of moving revival missionary health work in other countries. And this funding didn't just stop in the 60s, it went right through into the 70s and 80s, where new health institutions were building and growing. And this created a backbone of health infrastructure, the kind of system that someone like Frank Grant could utilize in distributing health resources and vaccines. It was then in the 1980s that the food aid programs that were coming out of the US were then able to use this infrastructure to distribute a huge amount of food, especially when in the 1980s, Ghana was extremely poor. In 1982, whether this is one thing that keeps coming back, and it's very hard to verify because at the time in the early 80s, as I mentioned before about the archives and the difficulty of information storage over a long period in some places, in the early 1980s, the country's information structure was breaking down. So it's very hard to verify some key things. But what seems to have been happening was in about 1982, half of Ghana's doctors and nurses left the country. The healthcare system, due to a range of government breakdown and struggle and conflict, was being very rapidly broken apart. There were other factors as well, including refugees being part of the country, and other circumstances in this particular moment in the life of the Ghanaian nation, which put a new pressure on the population. And so one of the things that as you get into the 1980s that happens is that healthcare institutions are very stretched. And some of those that are remaining, some of those mission hospitals that are able to keep functioning have very little health resources. They have very little access to medication or to equipment, and they just have what they can broker and barter. And you would think that this was a time when the Christian healthcare in Ghana was on its knees, when perhaps you wouldn't look to this period for innovation, but quite the opposite. One of the most striking things about Ghanaian healthcare in the 80s is it is a center of innovation. At a time when, again, the story people might tell about the country was that it was simply a recipient of aid, simply a need for resources, was actually a point when there were new ways of doing healthcare that were being practiced, being experimented, and being successful. To go to this, which is actually in the mid-1950s, but is an amazing image of local health courses with traditional village midwives. This is the kind of thing that was happening in the 80s. So in the late 1970s, well, into the 60s into the late 1970s, primary healthcare was being developed. And whilst it was taken up by the World Health Organization in the famous Alma Ata conference of the late 70s, there was a backlash against it, a pushback against it in the following years by countries who didn't want to invest in something that was entirely grassroots and didn't appear to be controlling disease, but actually more focused on the social determinants of health. What originally had started as a theological and missionary concept for doing healthcare had grown into a global health kind of vanguard, but was very quickly lost. But this is what was happening in Ghana in the 80s. It was being actioned, it was being grown, and it was being staffed regardless of any international agenda. There were missionaries pushing ahead with primary healthcare because they could see the difference that it was making, even in a setting that at the time was really resource limited. There were all over, especially with the Catholic missions. One of the Catholic missionaries told me primary healthcare was bubbling up. New ways of doing healthcare are emerging. And one of the concepts of primary healthcare that we often have let go is that it comes from a new way of thinking about salvation. In the mid-1960s, the Christian Medical Commission and the World Council of Churches were wrestling with the colonial legacies of health institutions. And they had a debate around the meaning and the relationship between salvation and healthcare. And there was an argument that if the story of Jesus was being told by institutions which were perhaps 18 miles away from where you lived, and perhaps was a hard road to get to. And yes, you may have got care when you got there, but that actually you may not have even had the opportunity to make such a hard journey. And it was only perhaps even the very few that were able to do that. Is that the story of salvation that we want to be telling? Primary healthcare was an argument in contrast to this that said, actually, if health workers from these hospitals came to villages to help with preventative healthcare, to teach courses, to teach classes, to deal with the low-level health problems that would generate much longer-lasting damage, if primary healthcare looked like that, this would tell a story that Jesus comes to you. He comes into the situation. He comes to your village. He isn't separate from you. He understands your context. He understands who you are. And in the 1980s, this was growing rapidly. This new way of doing healthcare was being experimented and grown across Ghana. As we get into the 1990s, the story of Ghana's healthcare is now in a context of a great deal more economic and political stability. And yet the healthcare system has, especially the faith-based aspects of the healthcare system, has outlasted, has outrun, and has survived amidst all different kinds of scarcity, of threat, and of shortage. And one of the things that strikes me about this story of really a resilient aspect of the health system, is it was made up of all different kinds of people. And that it was, in many ways, an example of a varied health system which was able to take on the shocks of economic instability. One of the parts of this is the relationship between those healthcare institutions, the local communities, local government, and different kinds of partners. This is a story of negotiation, a story of adaptation, and a story of innovation, which had a significant effect on the rest of healthcare around the world. This is not just a story for Ghana, but a story where Ghana has been able to grow a health system that has changed the way that global health has been understood as it was emerging following the 1940s all the way to the end of the 20th century. There are so many more intricate parts of this that I could share. But I overall want to conclude by capturing the principle underpinning what I've been talking about. Let's see if I can go to, I'll leave it on this image. The big concern that drives my work is how religion and global health relate to each other. It's the overarching question of this book. But the thing that I have found is that the legacies from the last century shape current interactions in this one, because patterns last a long time. Structural injustices, colonial geographies of extraction and exploitation, sources of labour, specific streams of development funding, and even particular individuals become embedded for decades. So when we are approaching some of the most challenging problems, whether they be in our own settings of Christian healthcare, or whether they be working with policymakers, or whether they be building networks and partnerships worldwide, understanding the historical connections and the historical roots of our healthcare systems today, and our understanding and comprehension of healthcare today will help us to find new ways, new innovative ways of tackling our current challenges. And we can't do those histories by just starting with the highest level policy making and working down to the ground, because that's not where global health really goes on. There are a diverse range of people who produce the meaning of health, who produce its histories, because power moves in lots of different directions and comes from many sources. And to make global health programs work, like I've shown with Frank Grant, with some of the Catholic missions, and with some of those that created primary healthcare, to make it happen, you need to understand the silenced communities, the individuals, the agencies who actually get crowded out, sometimes for the sake of neutrality, other times because they simply have not been remembered. And the neglect of religion, particularly in global health, often comes from a dislike of taking these local level people and ideas and their work seriously. Sometimes it's Eurocentrism. Sometimes it's concepts of the state and civil society that are imaginatively restricted by what we know of countries that have been able to do far more archival and research work, because they have not had the national narrative disruption that I talked about right at the beginning. But if we are increasingly aware of these complex historical processes, we can start to draw in more stakeholders that help us to build our healthcare in a way that does not fit with simplistic conceptions of African states or religions. It goes beyond the most powerful interests and beyond the most visible groups and networks. I'll be honest with you as I conclude. I have unearthed only a tiny part of this story. A tiny neglected part of it. I found the voices of a few different people. It doesn't even scratch the surface of the whole of the history of healthcare that has been going on in Ghana for more than 100 years. But if I've scratched the surface of a hidden history, how many more remain out there that could help us to rethink the future of healthcare and the future of the way we do it as Christians? What if the people who could challenge my narrative had the resource to write their own histories? If I found 1%, what's the 99%? And how would we reconsider our global health if more actors and voices could be heard? For me, that's the question that this research has left me with. It's a question rather than answer. What still is out there that could help us? Who have we forgotten that ought to be remembered? And how can we continue to adapt, to rethink, and to serve those who need it most? Thank you very much.
Thank you very much, Ben. We've been listening to Ben Walker telling us about the history of healthcare in Ghana and its interactions with the Christian church, the forgotten history, if you like. We've got a time now for question and answer, and we'll have a two-way on this over the next 20 minutes or so. So, Ben, thanks very much. The first question is, how did you get interested in this topic in the first place? Tell us a little bit about your own personal journey, which led you to this research.
Thank you for asking. I began wanting to understand how, as a Christian, I engage with global health, and this was when I was an undergraduate student, and I wanted to find out if there were ways of me being involved and where I could make a difference. I think that was where I first started to encounter some different theologies of global health, really, and in theologies of mission. I was figuring out when I was at university, what is cross-cultural mission now? What does it look like? What difference could it make? And where was I to take a place in that? And I love the proverb which says, with many advisors, plans succeed. And so I was talking to a lot of different people who were involved in this world and friends, and figuring out where I realized that actually there was a place for me in understanding the macro perspective, and that actually there was a way I could contribute. But I think one of the turning points was I made really good friends with a Ghanaian who was on the same course as me. We were studying an MPhil in African studies. And we both cared about some similar things. We had a shared faith, and we were working on our understanding of Ghanaian history together. And I think his role and his invitation were a huge part of that. I think we always know that these histories, the research we do, the healthcare we do, is not about individuals. It's about collective effort towards something. So I think I owe him and his family a great debt to enable me to do this kind of work.
Now, that's fascinating. It's always remarkable, isn't it, how God guides individual people down certain paths. Fascinating. And I guess it's often said that history is biased because it's written by the winners, or if you like, those who are in a position of power. And what you have done in your research is really try to go right to the grassroots and speak to people. As you say, you've gathered archives from all over the world, but also you've spoken to a lot of people and gleaned history that's not written down anywhere, but is only in memories and might be lost. So I just wanted to ask you, Frank Grant, when you started your research, was that a name you knew? At what point did you discover it and his particular influence and role? And how did you get to know about him and find out about his work?
Yeah, I started some of my initial research by interviewing the missionaries that I could find. Often in little archives, there are letters or scraps of reports that tell a little story about a group of individuals who may have started a health clinic or something. And so I began a lot of the research by following up to find out if there were some of those people who were still around, who were still alive.
Yeah.
And some of the first people I found, in the sort of late 80s, 90s, I did some interviews of the health clinics they'd set up in the 1950s and 60s. This will lead on to Frank Grant. But one of them was a working class Glaswegian woman who'd gone with her husband to set up a really small health clinic in the very far north of Ghana in 1955. And she stayed there. They stayed there about sort of 8 or 9 years, and with suitcases full of medication. And she kind of created health records on the back of the good luck cards that she'd been sent by her church as she left. There was no healthcare institution for them to connect to, and they were in a region of about 70,000 people, and they were encountering a lot of disease, particularly river blindness. And they decided they would do something about it. So they started to grow things. They then started to connect with, a little bit further away, there was a Catholic hospital. So these Glaswegian Protestants and this Catholic hospital start relating. And the connection between the two of them is so powerful, because one of them is in all the communities and the other has all the resources. And they start a relay system, which makes a huge difference to local healthcare. And I realized by doing these interviews and finding these individuals, I could start to unearth some more systemic issues and approaches. So when I started looking at smallpox, I was interested in the Wellcome Trust funded me to partly look at smallpox. I wanted to know who were the people that who were missing in this story. And Frank's name came up in a few reports that I was looking at, and then I was very grateful to have met his family and his late wife as well, and others. But it was really just discovering little parts of his life that began to put together to see that there's this huge difference this man had made in the work he'd been doing. I remember his family telling me about how he'd get up each morning to worship and pray before he set off on every health mission. These little parts of a man's life that you suddenly see are actually, as a whole, having a significant impact on many people.
Fascinating. And you hinted that his work in Ghana had ramifications for smallpox vaccination elsewhere as well. Can you just fill us in on a little bit of that story, that history?
There's only little pieces of it. But he seems to have done work, I believe, in India. I think, if I remember rightly, also in Sudan. I think also it may have been Burma and Bangladesh. There were a few different countries that he was making a difference in. And he was working with those who were running smallpox eradication worldwide. He later did work on guinea worm as well. There was a story about the WHO. He was a very tall man, and the Americans referred to him as the Ghanaian Abraham Lincoln. There was a story about him where the WHO Director General had arrived into Geneva without and lost all his luggage, and he went straight to Frank Grant's door because they were the same height. So he was a little snapshot of the story like that. I don't know what he was doing, but a little story that someone's remembered in a family or in and just like a little note or something like, or a letter, that's how you piece together these much bigger narratives. But yeah, that's a little bit of an indication of the ban.
Now, Ghana is one of over 50 countries in Africa, and you've done a lot of work on the history of healthcare there. Have similar histories been written about healthcare in other African or other countries that you're aware of? Are there other researchers working in this whole area?
Yeah, Marku Hokkanen has done some great work as well on, I think it was Malawi. There is also work on Nigeria that has been done. There's sort of patchwork histories around. There are some others, but they're often. I was very grateful to have the opportunity to be able to have the time and resource to put this together. I think that's a big part of this, is that no, there isn't. This is a huge area for research that simply isn't currently available. It's not that there's nothing, and there's a lot of amazing people in universities across the continent that are doing great work, but it's still an area that is underinvested and under-resourced.
Can I come back to this idea of the last mile? I guess it's the marathon analogy, isn't it? Where the last mile is the hardest, and you talked about the last mile being the pathway into communities where really health makes an impact, and how important relationships are to that whole context. And we know there's a lot of very big organizations, not least the WHO and other organizations who've come into places and at times of emergency or otherwise to address long-standing health problems. And they have this problem of not being able to engage with the local people who are going to put plans into action. Can you tell us a little bit about the engagement of Christians, particularly with the WHO? How mindful is the WHO of the importance of faith actors, and particularly in terms of implementing health solutions, at community level, the last mile?
Yeah, I think if to answer very specifically about the WHO is that they're increasingly connected, and they've created a WHO faith network, which is interfaith and which is able to facilitate some great dialogue in this area. Previously, in the sort of 70s and 80s, the Christian Medical Commission that I mentioned that did that work on salvation, they had like a monthly newsletter like that they called Contact, and it was required reading for WHO staff, because at that point Christian Mission was at the vanguard of healthcare innovation, and I think that we still are doing really interesting and groundbreaking work, but perhaps it doesn't always get fed through in the same way. Perhaps there are blockages, or there are reasons those voices aren't heard. And I think the WHO Faith Network can really help with that. But I think it takes all of us to work together to say, how can we participate in spaces where actually a Christian voice is not maybe being heard. But I also, to go back to the last mile metaphor, I often think of of Christian health work as a kind of ministry of reconciliation. The Catholic Medical Mission Sisters referred to their work. They did a lot in Ghana, created the Holy Family Hospital in Barakoom, amongst others. They say that the care of the body points to the care of the soul. And that's made one in the medical mission apostolate. It's not a snappy tagline, but it's a really good one, because what it's getting at is that actually there are two aspects of, I think, reconciliation that we do in the ministry of Christian health and healing. The first is building trusting relationships between different kinds of communities. Healthcare doesn't exist without trust. In order to heal the body, relationships and social interaction is a necessary part. It's not a helpful add-on. And this is something that primary healthcare was getting at, to really change the well-being and the quality of physical well-being in any community. You need to have improved relationships, good relationships between people, because actually the breakdown of relationship causes disease. It's most striking with cholera, that cholera follows war. But I think on a much lower level, actually, the health and healing is closely linked with our ability to make peace with one another. And then I think the other aspect of it as a ministry of reconciliation is what the medical mission sisters were getting at, that this is a part of us understanding the direction of where Jesus is taking us. The care of the body points to the care of the soul. It points to that reconciliation that we have through Christ. It tells the story of where we're going, and it tells the story of who we are and how God sees us and how he made us, and it reconnects us with that story. So I think health and healing is part of our call to be peacemakers.
And there's a comment, an anonymous comment here from an attendee who's saying, just a remark, so fascinating that the concept of primary healthcare is inspired by and models the gospel. And you've spoken eloquently about Jesus coming into communities to where we are, bringing healing of the body and the soul to us. He says, wish this was realized and acknowledged more by the WHO and generally. Sometimes something I'll try to remember when I find work tough and frustrating. Christianity's brought countless blessings to the world. Thankfully, this reality is being increasingly defended by writers like Tom Holland. And I guess it's a reminder of how incredibly important history is to understanding how we got to where we are. There's another comment here. I served in the upper region of Ghana where the greatest need in healthcare was malaria, cerebral spinal meningitis, protein caloric malnutrition, clean water, shortage of food and millet. There's just a comment there. Another question from Karen Patterson, who's saying, the face of missions changed in many ways over the decades and centuries. Has a historical colonial and religious factors been helpful or a barrier to Western missional and healthcare provision today? And what ethical considerations do we need to consider when we support either financially or by personnel overseas missional healthcare projects? What criteria might you suggest are ethical and considered good practice? And I guess she's getting at this move from formerly a kind of colonial model of mission, which was appropriate for that time, and then the more that sort of alma mater generation of community healthcare, public health, and working with communities. But your comments?
Well, I think that's a massive question, and I really appreciate that you've asked it. It's not one that I've missed. It's not an easy one, but it's one that we need to, I think, tackle head on. The first thing that strikes me about it, you're saying about what works and what should we be invested in. I think we should invest in things where there are strong local partnerships already in existence. New initiatives are great, and it's great to do new pilots of healthcare work. But actually, especially when things go wrong, who do people go to? Well, they often go to the existing health infrastructure. But actually, there's an opportunity when we build Christian health projects to invite the necessary stakeholders into that process and to make sure that we have those relationships. Because I think that it's healthcare that's lacked good relationship that is often the most destructive. But there's much more I could say there, perhaps another time. I think in terms of, you talk about colonial healthcare, I think that the thing that I would love to see in that whole area of debate is a full understanding or a growing understanding of the complexity of the role of missionaries across time, both expatriate missionaries, European missionaries, but also local missionaries that have grown out of or have been involved in healthcare. There are just like a couple of ways that I think we could begin to kind of nuance this area. One would be understanding that missionaries don't necessarily all agree with each other. I think in that debate, that kind of aspect of the kind of decolonizing debate, often missionaries are seen as homogenous, but they're not at all. They often had massive conflict with one another. Sometimes the most surprising groups would work together. Like Catholics and Protestants in the 1920s in Uganda, incredible effect and impact of their health on children and maternal health because of working together. But in many other contexts, they disagreed. Some were supportive of colonial organizations and some were radically opposed to them. So I think there's a complexity of understanding mission over time that I think we could take up. And then the other thing is that I wonder if when we're trying to understand how that healthcare has grown and changed, we understand where it wasn't just one country or where it wasn't just an expatriate role. Understanding from the very beginning where local communities and people have been involved. For example, Walima Kalusa does some great work on a mission. I don't agree with all of it, but does some great work on the auxiliaries in mission hospitals, local auxiliaries from indigenous communities, and how they adopted and reshaped new health practices that were being brought to them from the very beginning. There was a process of exchange, not only like donor recipient. So I just think I could talk about it much more. I probably shouldn't because we're running out of time, but that's my first thought.
You mentioned the work of CHAG, the Community Health or the Christian Health Association of Ghana, and I'm sure a lot of our listeners will be aware that many of the countries in Africa have CHA organizations, whether it's CHAG in Kenya or CHAN in Nigeria, and so on. And these groups are all united, of course, through the Africa Christian Health Association platform, ACHAP, which brings them all together. And of course, most Christian healthcare now is provided by nationals, indigenous movements and associations, rather than people from the West coming. Even though their contribution, obviously, in the past has been great. But I wonder if you could just can you tell us a little bit about the development of the Christian Health Association of Ghana when that started and what kind of role it has played in shaping Ghana's health system.
Yeah, I can certainly chat a little bit about that. I also noticed that someone has mentioned some work by someone called David Morley. There's just to say, I really appreciate you putting that in. That's really helpful to add other people that have written on this. It'd be like, so there's a lot of people that I haven't mentioned, a lot of work there that is out there that you can definitely go to. And like I say, my book is open access, so there's lots of footnotes and different writing that you can follow up if there's a particular context that you're maybe more interested in. Hopefully I've footnoted pretty rigorously, so you can find there like you say, if there's maybe other things that have been missed, but share those on your own on different platforms like this. With the Christian Health Association of Ghana, they're a huge role in bringing together Christian health organizations and mission charities. I think that if you step back from their contribution, in particular parts, if you look at the overall picture of it, one thing that they've created is a coherence and a voice to Christian mission. Because like I say, that actually there's a real complexity and sometimes a competitiveness, sometimes a cooperation, sometimes a collaboration between mission organizations and different partnerships. What the CHAs have done is able to draw some of that together and really, I guess, not only lobby, but also drive, policy changes and be a big, in Ghana being a big part of the national insurance schemes and helping those to establish the work of Peter Yeboah recently. Just really amazing Christian leadership that I think we can all really learn from, because he, where actually, again, perhaps the reconciliation and peacemaking is between Christians. For even in healthcare, the way they'll know we're his disciples is the way we love one another.
Absolutely, and that's probably a great note to end, isn't it? Jesus's prayer in the garden for unity amongst believers, and of course in the Last Supper for the love of believers for each other. That's the real sign of the truth of the gospel. So thanks so much, Ben, for your insights today. I'm sure people want to dip into your book and fill out more of the story you've told so well, and the heroes along the way. And we hope to see you all again soon on other ICMDA webinars. Do spread the word. And thank you again, Ben, for joining us today. God bless you.
Thank you so much for having me. Thank you, everyone, for listening.